I'm just handing over the session to Doctor Sir. So please come.
Good evening. I thank IIP for giving me this opportunity on this unusual topic, the rise of non-communicable diseases in children, Indian scenario. Basically, because of advent of antibiotics, the communicable diseases have come in control. The mortality has reduced, but because of lifestyle, there is rise of non-communicable diseases. The diseases which are not transmitted by a vector, person, or a media like water and air, they are called as non-communicable diseases. It's a general medical condition or a disease which is non-infectious, of long duration and of general slow progression. In recent times, they have attained a magnitude of epidemic proportions because of stress, strain, and change in the lifestyle. The main NCD, they are diabetes, cardiovascular diseases, chronic respiratory disorders, and mental health disorders. They are grouped under mainly 4 conditions. There are other many conditions like drug addictions in youth, then injuries, the other psychiatric disorders. Now, as you see, the awareness of non-communicable diseases, NCD, in school children is quite less in India, especially cancer, cardiovascular diseases. People think that this cannot exist in the children. So the awareness is very less. This is the graph depicting that thing. Now the risk factors for NCD among the adolescents are mainly they are reduced activity because of the screen time, increased screen time, mobile, TV, and the children are not playing in the ground. Then positive family history of hypertension, positive family history of diabetes. Obesity has gone to epidemic proportion. It's because of the junk food and erratic eating habits. Then pre-hypertension, stage 1, stage 2 hypertension, inadequate intake of fluids, fruits and vegetables, inappropriate dietary intake. These conditions, they continue to exist in the adult life. We have heard the childhood origin of adult diseases by increasing the risk for hypertension, diabetes and cardiovascular diseases. Now diabetes in children, Indian scenario, type 1 diabetes and type 2 diabetes mellitus. Of that, type 1 diabetes mellitus is common near around 12 years, 10 to 12 years, though we have seen from the infancy. Type 2 diabetes is common in adolescent period, especially in the obese children because of insulin resistance. And they have estimated more than 1% in children, they are diabetic. And this is old data, the 1964 to 1989 reported prevalence. Up to 2015, it is 10.2 per lakh population. And proportion of children with type 2 diabetes, they have reported as 12 to 26%, but I don't believe it. We have seen quite less type 2 diabetes. Then type 1 diabetes mellitus has 3 initial presentations. New onset of polydipsia, polyuria, weight loss, hyperglycemia, ketonemia. Diabetes ketoacidosis is one of the most common presentation in our scenario. Then silent incidental discovery. Stages are stage 1, beta cell autoimmunity, more than 2 islet antibodies, normal blood glucose, pre-symptomatic. Stage 2 is beta cell autoimmunity, type 2 islet antibodies, raised blood glucose, dysglycemia, and pre-symptomatic. Stage 3 is beta cell autoimmunity, raised blood glucose, dysglycemia, symptomatic, and stage 4 is long-standing type 1 or insulin-dependent diabetes mellitus. The diagnostic criteria are plasma glucose fasting more than 126 milligram percent on more than one occasion, random plasma glucose more than 200 in patients with classic symptoms, and plasma glucose more than 200 measured 2 hours after glucose load of 1.7 grams, that is oral glucose tolerance test. Glycosylated hemoglobin more than 6.5%. Then laboratory testing, we are hardly doing pancreatic antibodies, autoantibodies. Insulin and C-peptide levels can be done. Type 2 diabetes mellitus, asymptomatic, is around 40%. Glycosuria detected on urinalysis obtained as part of routine physical examination. Then symptomatic is 60%. Polyuria, polydipsia, nocturia, recent weight loss, vaginal discharge or fungal infections. Diabetic ketoacidosis, this is the most common presentation. Hyperglycemia, ketonuria, and acidosis, hospitalization, rehydration, insulin replacement therapy. Hyperosmolar or hyperglycemic state. Medical emergency is characterized by marked hyperglycemia, and sometimes they may present with coma because of hyperosmolarity. All children should be assessed for risk factors for type 2 diabetes mellitus, obesity, family history, high risk racial ethnic group, glycosylated hemoglobin more than 6.5%, fasting plasma glucose more than 125 or 226, random plasma glucose more than 200, GTT with plasma glucose more than 200 milligram percent, and test for ketoacidosis. The management, I will just go rapidly, we all know about this. Balance the goal of strict glycemic control, then reduce risk of long-term sequelae of chronic hyperglycemia, avoid severe hypoglycemia, set realistic goals for each child and family, train the patient and family caregivers, measure blood glucose concentrations, administer insulin, different types of prescribed insulin, how to measure, inject insulin, how to rotate the injection site, they have to be trained. Recognize and treat hypoglycemia, measure blood and urine ketone concentrations, maintain blood glucose with target range, maintain normal growth, development and emotional maturation and support, increasing independence and self-care of diabetes as child grows older. Type 2 diabetes mellitus, the goals are maintenance of near normal glycemic control and treatment of comorbidities, hypertension, dyslipidemia, non-alcoholic fatty liver diseases, with the exceptions of this, will reduce risk of long-term vascular sequelae. The pharmacological agents are used are they are metformin, insulin therapy, liraglutide, sodium glucose transporter 2 inhibitors, DPP4 inhibitors. We are hardly using this except metformin and insulin therapy. I will not go in the details of summary of pediatric weight management guidelines from Academy of Nutrition and Diabetes. Is you have to change the eating habits, reduce total dietary fat and calorically sweetened beverages, promote intake of vegetables, fruits, reduce consumption of food, reduce portion sizes. Do not strictly restrict the highly palatable food. This is the routine change in the food habit. We should improve it. Then heart disease in children is India scenario. The most common thing we encounter is congenital heart disease. Approximately 1.5 lakh to 2 lakh children are born with congenital heart disease in India every year. About 1/5 of these suffer from critical heart condition requiring early intervention, and currently available care for these children is grossly inadequate. Then rheumatic heart disease, estimated prevalence was pointed and by echocardiography now E-Doppler, it is around 20 per 1,000 school children. I think they are quoted quite high, 20 per 1,000. Diagnosis of congenital heart disease in affected newborn infants, parents, caregivers must commonly notice difficulty in feeding, color changes, cyanosis, persistent pallor, unexplained irritability, then excessive sweating, poor feeding, then poor weight gain, decreased activity, excessive sleeping, delay in motor milestones. Diagnosis is by physical examination, pulse oximetry, chest radiograph, ECG, hyperoxia test, echocardiography. Whenever there is cyanosis, respiratory symptom, difficulty feeding, poor weight gain, abnormal precordial activity, abnormal heart sounds, abnormal chest radiograph, ECG, they should be referred. The diagnosis of rheumatic heart disease occurs 2 to 3 weeks following streptococcal throat infection. The most common condition is rheumatic carditis, 30 to 80%, and arthritis. It causes pancarditis, pericarditis, myocarditis, valvulitis. Diagnosis should be suspected in all patients with acute rheumatic fever. Prevention of rheumatic heart disease, primary prevention, secondary prevention. Prevention of initial development of involves diagnosis and antibiotic treatment of streptococcal infection, predominantly due to tonsillopharyngitis. Recurrent acute rheumatic fever with continuous antibiotic prophylaxis is recommended for patients with definite history of ARF for diagnosis of definite rheumatic heart disease. Continuous antimicrobial prophylaxis is recommended because recurrent ARF can be triggered by a streptococcal infection even if asymptomatic. Adjust the duration of prophylactic administration. Then chronic respiratory disease in Indian scenario, allergic rhinitis, Indian study reported prevalence of 11.3% children in 6 to 7 years age group, at 24% in children aged 13 to 14 years. Asthma, overall prevalence rates of even asthma was 3.5% in age group 6 to 7 years and 4.5% in the age group 13 to 14 years. Allergic rhinitis and asthma coexist in 70 to 80% of Indian patients. The diagnosis of allergic rhinitis, identifying allergens, other triggers, allergy testing. Then treatment is avoiding the triggers. Steroid nose sprays, how to use a nasal spray, antihistamines, nasal irrigation, saline sprays, allergen immunotherapy. This we are practicing daily, so I will not go in the details of it. In European Forum for Research and Education Allergy Airways Diseases, management of algorithm for pediatric allergic rhinitis. So very complicated, I will not go in the details. Diagnosis of asthma: wheezing, noisy breathing, coughing, tight feeling in the chest, trouble breathing. It is diagnosed by spirometry, lung function tests. Then treatment is by inhalers, liquid pills, spacers, nebulizers, education, asthma diary, controlling asthma triggers. Children 5 years and younger, a personalized asthma management. You have to review, you have to assess, and you have to adjust the treatment. Step 1 is considered intermittent short course of inhaled corticosteroids at the onset of illness. Step 2 is daily low dose inhaled corticosteroids. And step 3 is double the dose of corticosteroids. Step 4 is continue control and refer to specific assessment. And relievers, you can add leukotriene receptor inhibitors or beta agonists you can add. These are again the same thing to prevent the exacerbations and control symptoms. Low dose inhaled corticosteroids and short acting beta agonist, they can be I will not go in the details. These are the GINA guidelines. Mental health disorders is the fourth major group of this NCD. According to Indian Journal of Psychiatry in 2019, at least 50 million children in India are affected with mental health issues. 80 to 90% do not support. Prevalence rate of child and adolescent psychiatric disorders in community was 6.4% and in the school it was 23%. The mental health disorders, mainly they present as anxieties, depression, oppositional defiant behavior, conduct disorder, ADHD, then obsessive compulsive disorder and post-traumatic stress disorder. Identify the warning signs: persistent sadness that lasts for 2 weeks or more, withdrawing from avoiding social interactions, hurting oneself or talking about hurting oneself, talking about death or suicide, outbursts or extreme irritability, out of control behavior that can be harmful, drastic changes in the mood, behavior and personality. Especially this can be seen in the children who are troublesome in the class, and you get repeated complaints of these children by whether they are disturbing the other children. These children especially can be investigated for psychiatric disorders. Then changes in the eating habits, loss of weight, difficulty sleeping, frequent headaches and stomach aches, difficulty in concentrating, changes in academic performance, avoiding or missing school. ADHD and infantile autism, though we say the percentage is quite high. I have seen there is a school which is attending infantile autism, autistic disorders. Almost 100 children are registered for these disorders. The managing mental health disorders discuss the child's developmental history, temperament, relation with the friends, family, medical history, interests, abilities, and any prior treatment. Information from children's school, such as standardized tests and reports on behavior, capabilities, and difficulties. Treatment options are psychotherapy or talk therapy, medications, family counseling, support for parents, and protective factors are loving caregivers, safe school environments, positive peer relationship. Now, approach to NCD or non-communicable disease prevention is primary prevention is by action that reduces the risk of diseasing development by avoiding unhealthy diet and improving the physical activity. Secondary prevention is early detection and management of disease so as to avoid serious complications. Newborn screening is one of the very important aspect of it. Tertiary prevention is to reduce the progress and impact of disease once a diagnosis has been made. Under nutrition and NCD, nutrition has got a very important and great impact on this non-communicable diseases, and NCD, they are rising in prevalence globally, and they are particularly affect younger and thinner people in South Asia, most likely due to poor early life nutrition. Long-term effects of undernutrition are reduced muscle and bone mass, stunting and wasting, increase the insulin resistance, and reduce cognitive availability. And that is the cycle, how the nutrition affects the health and is responsible for NCD. Childhood physical activity, sports and exercise, and non-communicable diseases, a special focus on India. Physical activity during childhood enhances physiological and psychological development, improves health status and quality of life of child. It delays or retards the evaluation of health risk factors that contribute to degenerative disease in childhood. It helps establish, maintain adequate levels of physical activity throughout the life. So physically inactive child, as we can see in the diagram, they are liable for blood pressure, obesity, dyslipidemia, insulin resistance, decreased bone density, other markers of cardiometabolic risk. And these diseases, they continue in the physically inactive adults, and they are responsible for the burden of non-communicable diseases. To summarize all, we must improve the nutrition of the children and should promote physical exercise, a reduction of risk factors and timely interventions, evaluate child for diabetes, identify and treat rheumatic heart disease adequately, and counsel about surgical intervention in congenital heart disease, counsel parents to seek support in case of mental health disorder of child so that children can have better life outcomes. Thank you.
Thank you, doctor. Thank you for this nice CME as a good speaking. So I am requesting as a Alembic to welcome to doctor for one. Thank you, sir. I am requesting to you that dinner is available, sir. Please kindly. Oh, sir, sorry.
One announcement. We are going to launch our YouTube channel. I request all dignitaries to come on stage only. Vaidya sir, Atul sir. सगळेच या सर. कंबाईन इकडे घे ना जरा मध्यभागी. गाडे संदीप. बटन क्लिक करायचं या सर. तिथं दिसणं गरजेचं. या ना सर. क्लिक कुठे
त्याच्यावर दाखवायचं.
संदीप.
Try to accommodate everybody.
सगळेच उन्मान आहे सर.
सगळ्यांनाच बोलवलं मी, त्याच्यासाठी नाव टाकलं नाही जेवढे तेवढे.
एक ही आहे.
इथे इथे. एक सेकंड. We have conducted 3-4 CMEs that we have done recording. This is the first day speech. Then this is late Sharad Kasliwal orations hepatology lecture. This is the CME on autism we have conducted. And this is the prevention of neonatal blindness. These 4 we have uploaded till now. Today's lecture is also recorded that we are going to upload. We are keeping some gap, 2 to 3 months gap to upload the lecture so that everybody should come for live lecture also. You can click here and subscribe also. This is इथं आहे ना. नाही पण इथं हे दाखवू ना ऑन करून. These are the promises I have given. I have to fulfill these. सबस्क्रिप्शन लग सर खाली येईल तुम्हाला लाईक आणि सबस्क्राईब येतं ना.
आला इथं राईट कॉर्नर आला. राईट कॉर्नर क्लिक कर खाली.
As we all know, great power comes with great responsibility, and I am ready to take responsibility for whole of the next year to serve for Solapur IIP. Similar responsibility was given to me as the organizing secretary in Mahapedicon 2015, and I have made sincere efforts, and along with all of you, we have made the grand success of Mahapedicon 2015, and I will do the sincere efforts for whole year 2023. As the IIP president. Good evening, Solapur audience. At the onset, I want to thank Solapur IIP for. These are the slides.
To start the scene, just 5 minutes. That's the same lessons that we have to learn.
And this is what these children at that particular age, 6 months to 2 years of the brain. Experiment studies were done of boiling.
No.
Okay, that's why points will not be given.
It gives me immense pleasure to
The autism CME we have conducted.
पण त्या वयातच ते डायग्नोज केलं तर त्याचा खूप उपयोग होतो. सो ऍक्च्युअली व्हॉट इज इटिएफ पाथोजेनेसिस वी डू नॉट नो. पडत नाही असं पण काही वेळेला होतं. आणि हे
हा कायम. I will just share the link in the WhatsApp group today only. And you can give your videos also if you have presented or you have got your own videos also. That can be also, we can upload on these sites also. And we will form some photos and a directory like, and we will create video, and that we will upload on this channel only, so that all members' presentation will be there.